Hello everyone, I'm sorry I can't be there with you in person, but due to the wonders of technology, at least I can join you online. I hope you're all having a really good meeting. What I want to talk to you about today is choroideremia carriers and what happens over time. I haven't done this work by myself. This was part of Senna's PhD, and she was supervised not only by myself but also Lauren Aiton and Tom Edwards, who are shown on the screen there. So I really can't talk about this work without acknowledging their input. And part of this project, Senna was supported by the Choroideremia Research Foundation on a travel grant to come over to England from Australia to come and collect the data. So thank you to the CRF for that. So this all started from observations that Tom and I made from when we both worked in Oxford. We noticed choroideremia carriers coming in and presenting in quite different ways. And whenever I refer to female, just for simplicity, in this context, I'm referring to anyone with two X chromosomes. So although vast majority of the female carriers were asymptomatic and had relatively normal looking eyes, there were a few that had more severe disease presenting. And so, there was always this notion that the carriers don't manifest choroideremia. But actually we were able to break that down. And so we came up with a classification system, which we published in 2015 in our initial work, just from observing the various carriers that came into the clinic or accompanying male patients. And that's what's shown on this slide here. So picture A, which is on the bottom left of the slide, is so all of these images, actually, before I describe each, is an autofluorescence image. So when you go into the eye hospital and you get the really bright blue flashing light, it's the one that everybody hates the most. But the reason we do that is because it lights up this particular layer at the back of the eye, the retinal pigment epithelium, and because that's one of the first layers to be affected by choroideremia, it's really helpful for us in identifying the disease and also in measuring what's going on with the disease. So for those of you who can see the slides, and for those of you who can't, I'll do my best to describe what's going on. You get a nice even white surface, and there's some black lines running through it, which are normal because they will be your blood vessels. And there's two little black patches. So one in the center is the macular area, because there's heavy pigment in the macula, which protects the macula from UV damage. So that also blocks the autofluorescence. So that's normal. And then the big black section on the side is your optic nerve head, so that's completely normal. But then other than that, it should be like a fairly even white sheen. So picture A is looking pretty normal, and that eye is not going to notice any problems with their day-to-day vision either. Then picture B, which is next to it and slightly higher up, is what we call a coarse pattern. And you can see there's patches of loss there because there's like punched out areas of black in the image interspersed in the white, but they're quite small areas. So that eye will, those cells, um, if you've got two eyes that have the same pattern, that will translate for that person that they can only they notice slight problems with their vision. So they might notice difficulties with their night vision, maybe a bit of difficulty in their side vision, but they'll largely be okay. Then picture C, which is also in the middle but lower down, is what we call the geographic pattern. So that's where you've got a block of kind of preserved retina. So you've got the block of white, and I know it's not completely normal, but it is preserved because it is white, and then the block of black, so the retina that's not working so well anymore. And so that's why it's called geographic, because it's a bit like a map. And then picture D, which is on the top right, is what we call male pattern disease, because that's what it looks like in a choroideremia patient, basically. And I know Senna's going to go on and talk about why some eyes, some carriers present at the milder end and some at the more severe end. But now that we've got this classification system, it makes any other work we do easier to then go on and monitor. I also hear people ask, well, why do we need to even look at carriers since most of them are asymptomatic? Well, yes, but not everyone is, and especially those at the more severe end, they will need as much support as our male patients and potentially treatment options too. So we can't ignore that issue, and we need to better understand the disease and whether it is in the we call it male pattern, but is it the same as actual male pattern choroideremia? And the ones that are asymptomatic, do they remain asymptomatic all their life? Like that was a big unknown. So I, we so Sana, as part of a PhD, did this big a global survey, and we were able to recruit. Thank you to all of those of you in the room who answered this survey when it came around, and I'm sure many of you will be able to voice your opinions on this. But we see this trend in healthcare more widely. Women are often ignored. Women do not get enough support and attention in healthcare, and this needs to be addressed. So it's really, really critical that we don't just brush matters aside because it's perceived as not important enough. Because it's not just about how symptomatic or asymptomatic someone is. You've also got to remember that women are mothers of patients, and that may come with a whole series of guilt. And carriers also are involved in decisions around whether to have a baby whilst carrying the gene. And that decision can be very difficult if we've not addressed all the questions. So I think there needs to be a lot more thought put into the healthcare support that goes into supporting carriers, and understanding not only predictive factors for that individual, but also the wider implications around being a carrier and what that means for the family. So with the help of the travel grant from the CRF, Senna was able to come over to the UK. We got in touch with all the patients that I'd previously seen in Oxford over many years there, but I was now working in Cambridge at the time. And we got ethics to follow these patients up. 17 carriers agreed to come back for follow-up in Cambridge, which was great. And we had a maximum follow-up of 11 years, mean follow-up of 7 years from their initial visit with me, which is a really good period to be able to see what's going on. And the first thing to look at is, does anyone actually switch from one category to the next? And reassuringly, if you start off as someone who's been classified as fine, you don't go into male pattern disease. So you might get a little bit more deterioration, go into course, but you don't go any worse than that. And if you start off as geographic, you might go into male pattern. So the two milder stages are aligned and the two more severe stages are aligned, but you don't cross between them, which is reassuring, especially for those in either of the two milder stages. Of course, what we don't know is if you're going to be showing signs of the more severe degeneration, at what age that would start. Like we know in males, that tends to onset in your early 20s on average, but we don't know what that is for females. Then we got our carriers to do microperimetry, another test everyone's really fond of. And if you could see my face now, you'd see the wry British smile. So this is a visual field test that takes into account the eye movements. An example is shown on the screen of the output. So the more green the result is, the more normal it is, the more warmer the color, the more abnormal. Black means you can't see anything. And you do get a slight decline in over time, but the milder your disease, the less the decline over time. And actually, most people don't have a hugely significant decline over time. So just to put this in context, the FDA, the Food and Drug Administration, they require an improvement of 7 decibels. So the numbers here, so it's the big gaps are 10. So you would need to go from up 3 little check marks for it to be counted as significant. Only a handful of people declined by that much over 10 years. So the vast majority of people did not have what we call a clinically significant decline over 10 years. It was a very, very tiny decline per year that you wouldn't really notice in your day-to-day life. which again is quite reassuring that it is so slow and very, very gradual change in the vision. We also looked at the imaging. So there were two types of imaging. So first of all, the fundus autofluorescence, which I've already explained, and that was the rate of decline in the cells um, in the two more severe types. So the geographic and the male type disease. And although we haven't compared it directly to the male type, it does seem to be slower in the carriers, although there is huge variability across individuals. The second type of imaging we looked at is ocular coherence tomography, OCT, which is the imaging that's a bit easier to do. That's when the laser lines are scanning across your eye, and allows us to look at the individual cells in your eye. And that and with that we were able to look at the change in thickness in the cells in different layers, and again plot the rate of decline over the years. And again, the more mild the disease, the slower the rate of decline. And again, it's reassuringly very, very slow. So we published all the numbers, but it is very variable across individuals. So we can give averages across our cohort, but really it really depends on the individual. I've already addressed the question of how clinical care can be improved, of how we can better support choroideremia carriers within the clinical setting, and how choroideremia carriers can be more appropriately referred and cared for. But another key question of this work is, should carriers be included in gene therapy trials? Well, absolutely they should, particularly the carriers who have more severe male phenotype, possibly even geographic atrophy. The carriers that are in those phenotypes are clearly struggling more with their vision, have a disease that is equivalent, that is showing functional and structural loss in their eyes that we can demonstrate, is showing decline that we can demonstrate, and so therefore would be expected to behave in a similar way as a result of gene therapy. So one of the concerns always was, well, if they had another X chromosome counteracting that, but again, from work Senna's going to show you, I don't want to give too many spoilers, but clearly that other X chromosome isn't behaving the way it should. So therefore, we shouldn't be treating it as if it is. And I would argue then that makes them eligible for any trials that are ongoing. But I also would be interested in hearing what the community think. I think when it comes to the milder cases, I do not see the benefit in putting them through something as invasive as gene therapy when there's clearly not going to be a benefit. So I would be inclined to reserve gene therapy for the severe cases, because the milder ones we can show are going to remain relatively stable. And thank you all for your attention.